Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 3 of the Pediatric Physical Assessment, which is entitled Using a Systematic Approach. The objectives for this session are to look at a systems approach to assessment, identify normal findings, because if you can identify normal, you will know what is abnormal. You might not know what it is, but you will certainly know that it is not normal. And then again, we'll do some revision exercises as we go through. Okay, when we review a systematic approach to assessment, you've got to remember, by using this system, you can save a patient's life by identifying reasonably quickly. It's often the only way to become aware of a specific problem. And as a consequence of that, you can determine the most effective treatment options. It commences at the head and ends at the toes and lasts for approximately 30 minutes. It can vary, depends on what you're finding. And it always measures the important vital signs we discussed in part 2 of Pediatric Physical Assessment. And it evaluates the body using inspection, palpation, percussion and auscultation. So when we look at the head, face and neck, typically we use inspection and palpation. And normal findings would typically include that the head is round. The face and the head are symmetrical. The features are not identical, but they're essentially the same on the right side as they are on the left side. The flesh or the skin colour is homogeneous. The skin is typically clear, smooth, and there is hair on the head. When we look at the eyes, you've got two. We'll be using inspection as the technique. Normal findings are that the eyes are typically symmetrical. The intercanthal distance is normally equal. The ear pinna is aligned to the intercanthal distances. Eyelids are there. Eyelashes, there's no discharge. The conjunctiva are clear and moist. The sclera is white and translucent. The cornea is smooth and transparent. The iris is flat and coloured appropriately. And the pupils are round and equal. Always look at the images. Always look at the people's face. In order to know when something is abnormal, you've got to have an idea of what is normal. Because if you know what is normal, you'll absolutely know what is abnormal. What you see, what you hear, and what you smell is what you know. 70%, as I said previously, of physical assessment is inspection. The nose, you've got one. The techniques that you'll be using are inspection and palpation, and the normal assessment findings are that you've got one nose, you have a nasal septum which is midline, you've got labial folds which are symmetrical, and there's no discharge typically coming out of your nose. When we look at the mouth and the tongue, the techniques that we would employ are inspection, and if we find something abnormal, maybe palpation. So when we look at the mouth and the tongue, the lips are smooth, they're moist, the gums have got a red surface typically. You've got sharp margins around the teeth. The gingiva are smooth and shiny. The teeth are firm in position. The tongue is midline. It doesn't protrude. The tongue is pink and moist, not dry, slightly rough, and it moves freely. There are no restrictions. You can open your mouth very easily. You can poke your tongue out easily. When we look at the ears, we'll be using inspection and palpation again. Typically you won't even be using palpation unless you detect a problem. It's typically only inspection. The normal findings are that you have two ears, the pinna or the top of the ear is level to the canthus of the eye. The placement, the height and size are equal. You can move your ears freely with your hands. There's no pain. And there's cartilage present in your ears. They're not floppy. They don't flop down. They have structure. They have support. They don't have a skeleton, but they've got a cartilaginous skeleton. And there's no discharge. And the lymph nodes, pre and post, lateral and inferior, are non-palpable. When we look at the neck, we only use inspection unless we see something that we need to touch. Now, the normal findings in an infant before the age of 2 years, they don't really have a neck. They do, but they don't. So very difficult to now palpate if required to do so. May be difficult to actually even inspect. But typically the trachea is midline. The thyroid gland, if required to be palpated, is smooth and mobile. The lymph nodes, if required to be palpated, you won't find them. They're non-palpable. And if you want to look at a jugular venous pulse, well, you won't be able to do that until after the age of 2, if required to do so. After the age of 2, they are more accessible. You can see things in the neck more clearly. Trachea, thyroid gland, cartilage, jugular venous pulse, etc. So let's review and remember. You got to remember, what you see is what you know. You've all got an idea, you've all got an idea of what is supposed to be normal. Just look in the mirror. God willing, you're normal. God willing, you don't find something that's abnormal. This little guy or girl appears to be normal. Bit of a pout. Looks very serious, but appears to be normal. Remember, look. What you see is what you know. Well, this doesn't seem to be normal. This little guy obviously has some issues. He's got injuries. So, this is definitely abnormal. He's got lacerations, healing, broken tooth, lip injury, trauma, appears abnormal. Oh, this little guy's got a pout. He looks very, very serious. Maybe he's just had a confrontation with his sister. Epistaxis, but look at the expression on his face. He's certainly not scared, that's for sure, but it appears abnormal. Multiple bruises, dilated pupils, severe facial trauma, bruising. Poor little guy. Appears abnormal. You know that this is not normal. Edema, erythema, papules, definitely abnormal. You're not diagnosing the condition, you're just identifying that there's something abnormal in the physical assessment. And then you will make a recommendation for expert consultation. Well, look at the kid's face. Alert, orientated, happy, playful, appears normal. When we look at the chest and back as we're moving down systematically, the techniques that we will be employing or could employ are inspection, palpation, percussion and auscultation. However, percussion is only used if an abnormality is detected. For example here, if you were inspecting and you saw that there were breathing difficulties and you auscultated the chest and you heard decreased air entry into the lower bases, you might put the patient into a position of comfort where they're semi-recumbent, and you might percuss to see whether there was dullness where there should be resonance in the lungs. And then you might refer them to a doctor or a specialist, and they'll have to have a chest x-ray. And the chest x-ray will identify whether they've got a pleural effusion. The physical assessment determines whether there is a problem, which requires further investigation. It's the first stage. When we look at the chest and back, the techniques that we're being employing are inspection. So what do you see? Typically, you've got a symmetrical chest. The skin is clear, pink, or what colour denomination according to their race. There's typically no edema in the skin, respirations are normal. The point of maximal impact, which is where the apical beat is located, is in the fifth intercostal space in the mid-clavicular line. The shape of the chest is typically flat, unless you've got here increased tissue there, because maybe the infant or the child could be overweight, or they may be prepubescent. Nipple size can vary. Nipples could be enlarged. Nipple pigmentation can vary. The spinal column, if we're looking at the back, should be straight on inspection. No protrusions. If we were using the technique of palpation, we must have found something that we're concerned about. When we touch the skin, it's typically warm and dry. The central capillary refill time, which means over the sternum, is less than 2 seconds. Peripheral should be similar as well, but we're not looking at the fingers or the toes at this present point in time. Skin turgor is considered normal. There are no breast lumps. Lymph nodes are not palpable. There's no crepitus, which means touching vibrations. The spinal column is intact and straight, and if we do touch it, which we're doing with palpation, there's no tenderness. When we use the technique of auscultation, you've got 2 types, cardiac and pulmonary. For cardiac auscultation, the normal assessment findings, which we already identified previously with palpation, is that the heart rate or pulse rate, heart rate with the stethoscope, is regular. Typical sounds would be S1, lub, S2, dub, lub dub, lub dub, lub dub. Typically, S1 is louder than S2. The best place to locate the heart sounds could be using Erb's point, which is typically in the third intercostal space on the left sternal border. However, S1 is best heard over the tricuspid and mitral sites, which we'll be looking at shortly, and S2 is best heard over the pulmonic or aortic sites. The best heart listening auscultation sites that are typically recommended in the literature for simplicity are as follows. If you want to listen to the aortic valve, it's recommended listen at the second or third intercostal space at the right sternal border. The pulmonic valve, second and third intercostal space in the left sternal border. Tricuspid valve, fourth and fifth intercostal space in the left sternal border, and the mitral valve in the fifth intercostal space in the midclavicular line, also referred to as the point of maximal impact, the PMI. A good general listening place for both normal and abnormal heart sounds is at Erb's point, which is located at the third intercostal space in the left sternal border. If you want to listen and learn about heart sounds, listen to your own. Get an acoustic stethoscope. Listen to your heartbeat in the recommended places which we've just mentioned. If you hear something that doesn't sound right, get someone who's a colleague, nursing or medical, to listen to your heart beat and give you feedback. Listen to your own. Hopefully you don't find anything abnormal, or hopefully you do, because then you can get something done about it if it's a problem. Adventitial or abnormal heart sounds can be numerous, and sometimes in pediatrics what is considered abnormal in adults can be normal in pediatrics, which is why, if it's identified, it may require a pediatric cardiologist to investigate and reassure the parents that it's not a problem, or advise the parents that it is a problem. So S3, or the third heart sound, follows S1 and S2, and the sound typically is as such: lub-dub-ta, lub-dub-ta, lub-dub-ta. Remembering the normal being lub-dub, 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 which reflects closure of the valves within the heart. If you've got a third heart sound that's pathological, it's typically related to congestive heart failure, which infants and children can be born with or they can acquire. So a third heart sound makes the rhythm sound like a gallop. It's referred to as a ventricular gallop, so it's lub-dub-ta, lub-dub-ta, lub-dub-ta. Listen to your own heartbeat, and hopefully you've got a lub-dub, 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 lub-dub. Not a third heart sound, lub-dub-ta, 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 lub-dub-ta. You can also have a fourth heart sound, which is associated with hypertension or aortic valve disease, which pediatrics can have as well. And the fourth heart sound comes prior to S1, which makes the sound talub-dub, 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 which is sometimes referred to as an atrial gallop rhythm. So S4 makes the rhythm sound like this: talub-dub, 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 talub-dub. Then there are murmurs. Murmurs are sounds produced within the heart as a result of turbulent blood flow. Normally blood flows through the heart, through the valves, from the right side to the left side, in a laminar fashion, in a straight line. No bumping around, no creating turbulence. If it creates turbulence, it produces an abnormal sound, which is called a murmur. And typically, there are many sounds that can occur. But usually, you might hear a whooshing sound. So for example, if you had a problem within the heart and blood didn't flow nicely, you might hear lab-whoosh-dub, 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 or lab-brr-dub, or lab-brr-dub, or lab-brr-dub, or lab-brr-dub. Something between the lub and the dub, maybe before the lub, maybe the after the lub, maybe after the dub. But you would hear it differently. It wouldn't be lub-dub, lub-dub, lub-dub. It would be lab-whoosh-dub, la bouche-tab, la brut-tab, la brut-tab, la prit-tab, la prit-tab. Something different. If you have a murmur, there can be different grades. And the gradings are typically from 1 to 6. 1 being faint or soft, and 6 being very, very loud. Now the faintness or the loudness doesn't indicate how bad it is, because it can be quite faint and you can still have a severe problem. Or it can be quite loud and you might not have a severe problem at all. But faint basically means you hear it with a stethoscope and it's soft. La brut-tab, la brut-tab, la brut-tab, la brut-tab. 6 can be very, very loud, and this can be heard with the stethoscope completely off the chest. So the bell or the diaphragm of the stethoscope are not even on the chest. It's lifted off the chest, not touching the chest, and you can still hear it. So la brut-tab, la brut-tab, la brut-tab, la brut-tab. Very, very loud. A murmur. A murmur is a sound which can be produced before S1, before S2, after S1, after S2, pre-systolic, post-systolic, lots of terminology. But the important thing is that you can identify there's no lab-dub, there's a labouche-dub, lab something dub here in between. And this will require expert consultation from a paediatric cardiologist to investigate. Then you've got clicks and snaps. Clicks and snaps are essentially short, high-pitched sounds caused by opening of stiff cardiac valves. Normally you don't hear the valves open, you only hear them closed. That's lab-dub. The valves are closing after they fill and after they empty. So the clicks and snaps are essentially probably calcified valves which are having difficulty opening. And this is when you hear snaps or clicks, sometimes referred to as opening snaps or ejection clicks. But again, will require investigation from a paediatric cardiologist. When we look at pulmonary auscultation, we've already noted the respirations are regular, quiet, effortless, hopefully. The typical rate we've mentioned previously, newborn 40 to 60, infant 20 to 30, child 10 to 15, in this classification. Now the normal breath sounds are tracheal, over the trachea, which you normally wouldn't listen to, but you could. They're very loud and they're harsh. Then you've got bronchial, which are less harsh. Bronchovesicular, less harsh. Vesicular, to do with the alveoli, they're quieter. They're not quiet, they are quieter. If they're completely quiet, there's a problem. Means no air entry. Always listen to the front and always listen to the back, because the lungs in the front are different to the lungs in the back. You have an anterior and you have a posterior. When listening to the lungs, the best listening or auscultation sites to hear the sounds are as follows. If you want to listen to tracheal sounds, listen over the trachea. And this is good. It's a good orientation for you, because normally you don't hear these sounds. But if you hear tracheal sounds over other parts of the lung, it could indicate a problem. Bronchial sounds are best heard over the body of the sternum. Bronchovesicular sounds are best heard between the first and the second intercostal spaces on the anterior part of the chest. Vesicular sounds are heard all over the lung fields. And always, as the diagram indicates, listen comparing right side to left side. Apices or the upper zone, the mid zone, and the lower zone. Always compare. Always compare right to left, left to right, upper zone, mid zone, lower zone. And that should give you an idea of upper lobe, middle lobes, and lower lobes in relation to air entry. Air entry should be equal. Sounds should be the same. When it comes to the posterior, same again. Always remember, you've got an anterior and a posterior. Try and avoid the scapula. Try and avoid the spine, the vertebrae, because again, sound isn't transmitted as well through bone. Just as with cardiac, you've got adventitial or abnormal breath sounds. And typically there are 4 categories. You've got rales, which you can also call crackles. You've got rhonchi, stridor, and wheezing. Now rales are classified as being discontinuous, clicking, bubbling, rattling sounds heard typically during inspiration, but they could be heard during expiration as well. And they typically sound like cellophane paper being quietly rumpled. Or some people say you can get your hair and rub it near your ear and it will sound similar to that. But rales typically are snapping open of the alveoli and the airways during inspiration. Rhonchi are a little bit lower pitched, and they're sort of rattling sounds that resemble snoring, and they're caused by secretions in the large airways. And it's partial obstruction of the airway which makes these sounds. Then you've got stridor. Stridor is a noisy, high-pitched inspiratory sound typically caused by severe obstruction. Could be in the nose, the mouth, the sinuses, the larynx, or the trachea. It's an upper airway problem, the proximal airway. In infants, you might hear it in infants with croup. Then you've got wheezing. Wheezing is musical. Wheezing is typically a high-pitched, coarse sound produced by bronchospasm or narrowed airways during inspiration or expiration, or both. Typically, it's related to expiration. You can't get the air out. And this could occur with asthma or airway diseases that cause bronchospasm. So let's review and try and remember. You've got, and again, look at the pictures. Look at the pictures. Look at the kids. Look at their eyes. Look at their expressions. Inspection. You've got a little girl with, looks like a salbutamol inhaler, a bronchodilator medication. She's got a noisy, high-pitched inspiratory sound, probably caused by croup. She's probably got a stridor, which is a noisy, high-pitched inspiratory sound. Review and remember. Well, I don't think there's anything wrong with this kid. He seems to be smiling. He seems to be okay. But he's got a deformity on his anterior chest. So there's the problem. So you don't have to know what the problem is, but you've got to identify that there's something wrong. And he's got an abnormal thorax. This is called pectus carinatum, or in lay terminology, a pigeon chest. Because when you look at your pigeons, their chest goes out. Here you've got a young girl with a very deformed spine. You don't have to know what the condition is, but she may be having breathing difficulty. She may actually be having pain when she comes into your emergency department. You identify that there's an anomaly. She's got an abnormal back, an abnormal spine. This is a scoliosis. Then you've got this boy and this girl. Again, you don't have to know what the problem is, but geez, they've got something wrong with their sternum or their anterior thorax. They have an abnormal chest. This is called pectus excavatum, or funnel chest, because it goes in, it's a funnel. You just have to identify that this is not normal, because you know what a normal chest looks like. That's the important thing with physical assessment. Identifying what is normal and doing something about it. Identifying something that is abnormal and doing something about it. Now you've got cute little infant. However, on auscultation, there's a loud, harsh murmur at the left lower sternal border. La bouche dub, la bouche dub, la bouche dub. A little bit faster in the little infant. La bouche dub, 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 la bouche dub. Not lub dub, lub dub, lub dub, lub dub, lub dub, la bouche dub, la bouche dub, la bouche dub. Kid's got a murmur. So you would escalate that to a physician, and the physician would escalate that to a pediatric cardiologist, and they would investigate it. So there's probably a heart problem here, which could be related to congenital heart disease, maybe a ventricular septal defect, but there are numerous. See, look at the infant. You can be quite healthy looking, stable, and still have a problem. And this problem will get worse as she or he gets older. So it needs to be identified and treated or corrected if possible. Now let's look at the upper limbs, and the techniques that we'll be employing are inspection and palpation. The upper limbs, normal assessment findings would be symmetry. Skin colour is homogeneous. They've got normal fingers. They've got 2 arms. They've got 2 hands. Their arms are symmetrical. When they move, they're coordinated. The joints are not swollen. They're equal size. The skin is warm, smooth and dry. If they grab your fingers or your hands, palmar reflex. They've got equal hand strength. Pulses when you palpate are of equal volume and strength. Capillary refill time, centrally and peripherally, is now less than 2 seconds. Lymph nodes are not tender in the axilla. The joints are not tender. The veins are soft and they're pliable. They've got a thumb. They've got 4 fingers. When we look at the abdomen, as we move down in our systematic approach, the techniques that we'll be employing are inspection, auscultation, palpation, plus or minus percussion. Depends on what we find. So the normal assessment findings would be, in a newborn, or slightly older than newborn, clean, dry umbilical cord, if it's relevant. Symmetrical contour of the abdomen, which could be flat, concave or convex. The skin is typically warm and dry. The colour is homogeneous, it's the same. Their muscle tone on palpation is good. There's no tenderness. The umbilicus on inspection is centered, and reviewing now whether they have an anus, their anus is puckered and typically darker than the surrounding skin. When you auscultate, their vowel sounds are high-pitched and occur every 5 to 15 seconds in an irregular pattern. There's no tenderness on palpation. There's no rigidity. It's soft and compliant. When we assess the abdomen using inspection, auscultation, palpation, plus or minus percussion if required, we typically divide the abdomen into 4 sections or 4 quadrants. The right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. Within these quadrants, the right upper quadrant typically contains the liver, right kidney, gallbladder, parts of the colon and pancreas. The right lower quadrant contains the appendix, right ureter, parts of the small intestine and colon, and segments of the right femoral artery and right saphenous vein. In the left upper quadrant, we have the stomach, kidney, spleen, parts of the colon and pancreas. In the left lower quadrant, we have plus or minus the stomach, parts of the stomach here, the left ureter, small intestine, colon, left femoral artery components, and left saphenous vein. In the midline, typically this is where you would locate the aorta, components of the small intestine and large intestine, in addition to parts of the pancreas, the bladder, and the spine. The abdomen can be further subdivided into 9 quadrants, which contains the right hypochondriac region and the left hypochondriac region and the epigastric region. Below them we have the right lumbar region, the umbilical region and left lumbar region, and below them we have the right iliac region, the hypogastric region and the left iliac region. And this makes it more specific in relation to where organs could be located, especially if you want to identify pain areas, which would be possible, I guess, for this little infant that we're looking at now in relation to tenderness on palpation. Asking would not provide much information, so that would be more specific to older children and adults. So let's review and remember now. Look at this kid. We're looking at it from the abdomen. Typically, this looks like a normal abdomen. It's flat and the kid's happy. So obviously there are no problems that we are aware of. Look. There's a protrusion just above the diaper. An umbilical hernia. You don't need to know that this is an umbilical hernia. You just need to know that there's a protrusion which is not normal. I don't think the infant is happy. I'm not sure I would be happy either. There's something wrong with the abdomen. It's obviously distended, and it must be causing the poor little girl some discomfort. Well, we've got bowel outside the abdomen. This is not normal. This is gastroschisis, which basically means that the intestines are outside the abdomen. Let's review the lower limbs now And with the lower limbs, we're looking at techniques that relate to inspection and palpation. Normal assessment findings, very, very similar to the upper limbs, except we're related to the legs, the feet, and the toes. Skin colour is the same, symmetrical, homogeneous. Skin is warm, smooth. Muscles, when palpated, are firm, not floppy. Legs are symmetrical, equal length, equal size. Feet are appropriately proportioned. They're the same, they're not identical, but they're the same. Toes, toenails are normal. No joint swelling, tenderness. Palpable pulses, whether it's now femoral, popliteal, dorsalis pedis, posterior tibial, etc. Capillary refill time is less than 2 seconds. Inguinal nodes are not tender. Veins are soft and pliable. They can move appropriately, regardless of age group. Let's revise and remember, what you see is what you know. If you don't know anything, you won't see anything. Remember what you consider to be normal. You all have an idea of what normal is. Using sample, which of the following assessment findings would concern you and why? This little kid's alert, has no allergies, is on no medications, has a normal birth and immunisation history. The last meal it had was breastfed by its mother 2 hours ago, and look, it's just had a bath. No concerns, appears content and happy. Look at the images. This kid's alert, really upset, salivating, has no history of allergies, on no medications, had a normal birth, all immunisations were given, development is okay. His last meal was breakfast about 6 hours ago, and he's had no food or drink since that time. There's no concern here, but the kid's really hungry and no one's attending to his needs. Maybe his mother's watching a soap opera. Oh, for goodness. Look at the image. This kid is furious. His face is flushed. He's really upset. He's alert though, and he's crying. Poor little blighter. He's got a history of no allergies, no medications. He does have a history of having tantrums though, getting upset very, very easily. His last meal was dinner about 4 hours ago, and the recent events were he was told to go to bed as it was his bedtime. He's got to go to preschool tomorrow, kindergarten. Well, there are no real concerns from a physical assessment point of view. He just doesn't want to go to bed. Once you know the history, you can put 2 and 2 together. History is important to determine physical assessment findings and whether they're a worry or not a worry. Now you've got a little infant. Respirations 45 breaths per minute, temperature 39.6 degrees centigrade, hot dry skin, having seizures, history of no allergies. However, every now and then, PRN, when required, he has paracetamol. He does have a history of febrile convulsions, and his last meal was breastfed about 4 hours ago. Events, his mother was alerted because of his crying. When she went in to him, he was difficult to rouse and lethargic, and he was unsettled. And he seemed to be stiff. There's a concern here. The kid is flushed, stiff, tremor, possibly. He could be having a febrile convulsion. Note the temperature. Note the skin. Note the fact that he's having seizures. Little 5-year-old boy. He's alert, feeling quite miserable. He's got a headache, a sore throat, he's constantly sniffing, his temperature's 37.7. He has no history of allergies, he's on no medication, he's quite a healthy little kid, very active. His last meal was dinner the previous night, and the events essentially are that he woke up this morning with a very sore throat and feeling awful. It's probably a normal concern. Maybe he's getting the flu or just a cold. Now you've got a very anxious and wheezing 7-year-old boy. He has a history of allergies in the springtime, or if he's in an environment where it's dusty or pollen is in the air. He's typically on salbutamol inhaler and betamethasone because he has a past history of being allergic to certain things, and he's an asthmatic. His last meal was dinner on the previous night, and the events leading up to this situation were that he was playing outside and he suddenly started gasping and wheezing. His mother panicked and quickly called the emergency medical services. There's a concern. He's probably having an asthma attack, which doesn't seem to be responding to his normal medications. This could be status asthmaticus. Okay, that's the end of part 3, which is the concluding chapter to pediatric physical assessment. If you've enjoyed it, please check out any other Dr. Manny Learn Shops, or look, advise me about Learn Shops that you might be interested in or you might want an extension of. Thanks very much. See you next time.